Welcome to Your Practice, Your Money, the podcast where clinical success meets financial freedom. I'm your host, Dr. Dimitrios Kostopoulos, and in every episode, we bring you actionable insights to grow a thriving and profitable healthcare practice. Are you charging what you are worth? Are you attracting and keeping the right patients? And could perhaps diagnostic testing be your next major revenue stream? And is your practice truly set up to work for you, not the other way around? Well, if you are a physical therapist, a physician, a chiropractor, a podiatrist, or any type of healthcare entrepreneur, this show is your roadmap to next level success. So let's dive in. I have with us today a very good friend, a clinician, a board-certified physical therapist in clinical electrodiagnosis, a manual therapy guru, and a mentor for electrodiagnostic studies. And this is my very good friend, Dr. Daniel Neff. Dan, thank you for joining us. I want to just get a first basic question. How do diagnostics, especially EMG testing, how do they change the role of the physical therapist in patient care?
Well, let me first start by saying thank you for all that you and the HODS organization does for promoting physical therapy and advancing our profession and trying to hold it to a higher standard. So I know you guys are dedicated, and thank you. Thank you for all you do.
Thank you.
As far as the role of physical therapists and kind of the value of physical therapy, I think that electrodiagnostics is like harmonious with physical therapy. You know, we see patients every single day that have numbness and tingling, weakness, and those patients then in turn need a study to specifically diagnose where that origin is. So the two of them are very harmonious together overall. When I think about the value overall of diagnostics in our practice, I can't help but think of a story that literally happened to me this past month. So us as physical therapists have this ability to, through our training in PT school, to do a physical exam on a patient, get a diagnosis, and we're pretty good at that. And as time goes on, we progress our profession, we get better at that, right? So we have that piece of the puzzle. And diagnostics then adds this neuromuscular component of diagnosis to it. So we have that piece added. And now we add musculoskeletal ultrasound, and we're very, very good at diagnosing where the origin of pain is. So it allows us as physical therapists to be really specific as far as being the diagnostic profession of choice. I always try to think when I make decisions for our practice about the mission. And the mission has always been to be a primary care clinic. You know, from day one, it was, people are going to come here first. But to do that, we have to be really good at, diagnosing their injuries, because when you talked about outcomes, right? If someone has, numbness and tingling in their feet, and we start working on their spine, doing manual therapy, and the patient has a polyneuropathy, our outcome is, not going to be quite as good. So Differentially diagnosing it is a huge issue. My point being is when we talk about the value of diagnostics overall, I had a patient I saw a month ago, 30-year-old male comes in, numbness, progressing numbness and tingling, uppers and lowers, progressive weakness. So I do the EMG study, and he has like clearly a global demyelinating problem. I called a physician and I talked to this physician about the results of the exam and what my thoughts were overall. Now, this physician, we've always had problems with getting our plan of care assigned, getting anything back on time. She's a hospital-based family practice physician that doesn't refer patients to us. But I call her and I talk to her about this case. I see a patient this past Tuesday that comes in with a script for an EMG from her, and the patient walks into the eval room and says, "Hey, this physician told me that regardless of what happens with this EMG, she wants me to have physical therapy at this practice because you guys are excellent." And I was like, "What the heck? How does that happen?" So I don't know how you put value on that. Like, how do you value your reputation? Those are the types of things that I think changes us as a physical therapist to a higher level. Diagnostics allows us to practice at a much higher level than physical therapy alone.
This is very, very important in terms of realizing the value of diagnostics, especially EMG testing, MSK ultrasound testing in physical therapy, in a physical therapy clinic, and the impact that it has in physician relationships, but also in society. And we're going to be raising the standard competency of physical therapists, the residency training in clinical electrophysiology compared to physician pathways, because we have a variety of physician pathways on physicians becoming electrodiagnosticians. And we have the residency pathway that many physical therapists follow. And actually, there are studies out there performed not only by physical therapists, there are studies performed by physicians, which I am going to quote in that white paper, that demonstrate that the training that physical therapists receive is way superior to the training that many physicians receive in terms of electrodiagnostics. It's mind-blowing, but hey, I'll tell you that just very small anecdotal evidence in terms of hours, the program that you and the rest of the people who are with us today, who are in the residency program, you graduated that program, you became board certified, you spent a minimum of 2,000 plus hours in the area of electrodiagnosis. A neurology resident spends somewhere between 160 to 320 hours, or a PM&R resident spends about a third of the time that you spend in that residency program in the area of clinical electrodiagnosis. So not only EMG nerve conduction studies are really adding value in a physical therapy practice, but they are performed also by highly trained, very competent individuals. I'm so proud of that we are able to offer this. Now, I want to look a little bit about the patient flow, right? A new patient comes into the practice. Can you walk us through what happens with that new patient, how they flow through the clinic from the initial evaluation to doing diagnostic testing, to treatment, to reevaluate? What is that patient flow?
We initially sat down as a group, leadership board of our practices, and essentially said, like, again, the mission is to provide these patients with a diagnosis of what's going on, where the origin of pain's coming. So we sat down and made goals for our practice, as far as the referrals of in-house patients. So essentially, that patient gets referred to us. They fill out a diagnostic screen, and during that initial examination, the patient is examined for physical therapy, for spinal restrictions, everything that we do on a daily basis. Now, when that patient has numbness and tingling or weakness, we have found that the outcomes completely change when we do a diagnostic EMG on that patient, because how many times do we see a patient that comes in with neck pain that has some sort of double crush, ulnar neuropathy across the elbow, median neuropathy across the wrist? They have a double whammy. So if we only focus on that patient's neck pain as far as their numbness and tingling is concerned, we're missing a component of the outcome, and we're not doing our job efficiently. The patient's still going to go away from this clinic with numbness and tingling. So essentially for us, when this patient comes in, all the paperwork's filled out and we kind of double check. So the DPT is responsible for looking at all of the paperwork, make sure that the No Surprise Act signed, the consent to treat, all of that signed, that if we have a script, we look at the script. This is one of the tools that we utilize. If the patient has numbness and tingling, they have any difficulty in weakness, or any of the past medical history issues that are listed there, and then we refer that patient immediately for an EMG test. So the flow of the clinic is that patient is told immediately during the first examination. So that patient, all of our therapists are educated on EMG, so they know that how to explain to the patient the benefits of an EMG and why they are referring them to have an EMG. So essentially, that patient then goes out, the EMG is scheduled, as well as their physical therapy treatment is scheduled as well. And then what we try to do is we give a brief examination when it's an in-house referral. We give a brief examination impression to that patient, but we send the results back to the DPT so that they can explain it to them. So again, you're having this situation where your clinical personnel are held to a higher standard where they are the referring clinician, and then they don't interpret the results, but they go over the results with the patient so that that patient knows that every time that I have pain, I'm going to come back to see, Dr. Max, Dr. Chris, whoever it may be in our company. So it's not just, me doing the EMG or Adam doing the EMG. The clinician is held in that high regard with that patient because, we don't have an endless supply of patients. Like, we're going to get the patients from our region, and we need to keep those patients for life. So we allow the clinician then to explain the results to that patient.
The physical therapists who are not trained in electrodiagnostics, they have a communication in some capacity with the therapist who performs the testing, so that that communication can lead then to the therapist who performs the treatment to be able to apply the proper treatment, taking into account the results of the electrodiagnostic testing then.
Absolutely. I mean, they read the report. I had one of our therapists come up the other day, and this patient had some borderline like sensory testing, and he's like, "Hey, do you think this is like early in developing polyneuropathy?" And I was like, "Yeah, you guys are getting it." Like, they can read now not only the waveforms and the data, but they understand what the EMG is. So they put that into practice, and it just takes time educating your therapist on what's going on, and they want to learn. I mean, they want to understand this. It helps them overall in their practice and building a quality practice.
There are physical therapists who have not been trained in electrodiagnostics, right? They are trained on manual physical therapy, You are a manual therapy expert. And sometimes there is this misconception that, hey, referring the patient for electrodiagnostic studies will undermine the value of my physical evaluation, will undermine the value of my ability as a physical therapist to identify the functional pathology of that patient. And therefore, I do not need the electrodiagnostic testing. And sometimes I give a parallel, right? That you have a patient, they walk into your office, let's say, and they tell you that they feel dizzy sometimes, okay? And you don't assume that because the patient is dizzy, that they have blood pressure problems. It can be something else that causes that dizziness, let's say. You are going to take the blood pressure of that patient. You are going to check the glucose levels of that patient. You are going to look at, evaluate the vestibular apparatus of that patient. So the fact that somebody will send a patient to receive a diagnostic test not only does not mean that the value of their service or the value of their ability to um, evaluate and diagnose a problem is not diminished, it is even strengthened because they have the deeper understanding of diving into more specifically into that patient's condition. But you are a manual therapy expert. I want really your viewpoint on this too.
Let's just talk about a patient that comes in. And so one of the reasons why we allow the clinicians to go over the results with the patient is so that they don't feel that way, right? If they just refer an outside test, they get the test, the patient gets the results. There's no talk, there's no coordination of benefits, there's no coordination of treatment. There's no like, hey, you sent me and I got fixed. You sent me to the right place and I got fixed. That's one of the reasons why we don't have that issue with therapists thinking that it's going to somehow undermine them because they're the referring therapist. They're the one who is going to, go over the results. So that helps for one. But when you talk about outcomes for that therapist, so we have a patient with L5 radiculopathy. I wish I could say, my manual treatments like heal every single patient. You have a large, discal structure that's pressing on the nerve, and I just can't, I can't get it off of that nerve. We know that right away that this patient has an active process. It's actively compressing the L5 nerve root, resulting in weakness, numbness, tingling, those type of things. So we're going to try to fix that patient. We're not going to refer them out immediately. We're going to try to fix that patient. But instead of keeping that patient for 3 months and then burning all their benefits and then sending them to a physician for a surgery, we know right away that, hey, if this patient doesn't get better in 8 or 10 visits, we are going to make the appropriate referral because we're going to dictate this treatment moving forward, right? We're going to make the appropriate referral. I've literally, and this has helped our practice. I literally sat down with a practice 2 months ago, an orthopedic practice, and said, look, we sent over 100 direct referrals to you for either surgery or pain management last year. You have sent us this many referrals. Like, we are considering sending to other different physicians groups who are going to work with us. It helps us overall. It not only helps the therapist with outcomes and knowing how to refer properly, and that has been a huge focus on our practice, is making appropriate referrals. Because if you're going to be a primary care, you're not going to heal everything. You have to make appropriate referrals. I don't think that our guys feel or girls feel that it's somehow undermining. I think it's just a culture of like, we're going to get this patient better or we're going to make the appropriate referral.
The fact that you have diagnostics into your clinic, does it have any effects in the reputation of the practice in the area?
I say this with a heavy heart. So I like to try to hang out with different practitioners and just to like increase my knowledge base. So I'm hanging out with this rheumatologist, and he's talking to this other rheumatologist who has rheumatoid arthritis, and they're talking about classes of medication. Right. And it was a super interesting discussion, like changing classes, when to change classes, and they were arguing back and forth. Right. So he introduces me. This is Dr. Neff. He's a physical therapist, and the rheumatologist that was a patient continues to talk about classes of medication. And the physician, the rheumatologist that I was hanging out with, says he also is board certified in EMG. And the guy immediately stops and starts talking to me about EMG. And I was like, I felt bad for our profession, physical therapy wise, but it's a different skill level. So I think your reputation overall is, with the knowledge that we get and the ability to talk through that knowledge with a physician, like, my goodness, like all of the physicians that we talk about don't understand demyelinating. They don't understand axonal. So when you're able to talk through that with a physician and show them these are the problems with your patient, this is how you should move forward with the patient, like your reputation immediately gets elevated.
I was told actually that you brought a little spine or something that
Yeah.
you could just give an example demonstration of the nerve compression or something like that. I mean, can you show us?
Essentially, what we try to do is with these facet joints, right? They have movement in them. And what ends up happening the majority of the time is we do something, crazy. We bend over, go cut wood for a week, and we get an inflammatory process that occurs at this level. Inflammation in itself is irritating to the nerve root level. It also causes, over time, if anything's over a month, it will cause some fibrotic changes in this facet joint. So our goal overall, we found that the segments that don't move in the spine, the segments that are restricted, essentially cause an overuse syndrome at a different level that's moving appropriately. Because the spine moves compositely through all of these joint structures, the restricted ones then put increased pressure, the ones that do move. So what we do is we go in and we figure out which joints are not moving. We go in and put a generalized force into that. Sometimes it's aggressive, sometimes it's, fairly mild overall. And we stimulate the 1A fibers here. The 1A fibers then go up to like the periaqueductal gray, the rostroventral medial medulla. These are all pain inhibition centers, come back down, and we see an immediate change in the tone of the muscle. We see an immediate change in the facet joint movement. So then we just facilitate movement within these areas, and then essentially the body heals itself once the mechanics are changed. We also look at the pelvis. Pelvis is a huge generator of pain. We look at the pelvic innominates to make sure that they are symmetrical. If not, you can get increased pressure from those 1A fibers in tension. So we'll do some manipulations to the SI joint. Overall, we'll manipulate the SI joint. We manipulate the pubic symphysis to make sure everything is mechanically correct there. But essentially, it's facilitating the proper mechanics so that the neural input can get to where it is. I mean, we have these patients with peripheral neuropathy. So when we talk about mobilizing, they have numbness and tingling on the plantar surface of the feet. These nerves are responsible for telling the plantar surface of our feet, what to do. So we go in, we manipulate the sacrum, we manipulate all the L5, S1 nerve root levels so that the neural nourishment can get to the feet. Because if you have peripheral neuropathy, you have, blood issues, you have nerve issues in the distal portion of these nerves, and you're not getting what you need to heal it from here, it's not going to get better. So essentially, even with our peripheral neuropathy patients, they do very well with spinal mobilization, spinal manipulation.
That's awesome. Look, we published a study a few years ago, and that study identified that almost 61% of cases, the patient management changed as a result of the electrodiagnostic result. And that was pretty much in a similar capacity in a previous study that was done and published on Muscle and Nerve, where they found about 50, 52, 53% in that other study, patient management changed due to the electrodiagnostic studies. Now, in your practice, do you see that happening? Or let's say, when you see that happening, do you modify the treatment?
Yeah, I think that's probably pretty accurate overall. Again, I think like correctly diagnosing everything that's going on with this patient, right? If you have a patient, the majority of our patients have back pain, right? If you don't have electrodiagnostic studies and that patient comes in for back pain and they actually have a polyneuropathy, the reason that they're getting numbness and tingling in their feet, and you just work on their spine, it may get a little bit better, but the outcome is not going to be the same. So understanding what you're dealing with is a huge difference in the outcome of your patient. The patient has numbness and tingling, in the distribution of the C6 nerve root. They're complaining to you that they have chronic neck pain, which we all have chronic neck pain. And you do identify it's a C6 nerve root level, whether, if it's an active, that kind of changes things. If it's an active compression, you're getting denervation. Is it a chronic stable C6 radiculopathy? That changes your treatment. Like an active process, maybe you're not going to get quite as aggressive in the spine. You're going to do some different mobilizations. Not that you're not going to go there, but you're going to change on, what you're doing. You may add some different things if it's an active process. If they have a superimposed median neuropathy at the wrist, now you're going to add, some carpal mobilizations. You're going to mobilize all the bones in the patient's hand. You're going to mobilize the nerve. You're going to mobilize the fascia all through here so that you can address the median neuropathy at the wrist. If not, you miss that. One of the things that I'm seeing now, and I literally on Tuesday, I EMG'd a physician. He had had a previous cervical fusion, but he was having numbness and tingling in these three fingers, waking me up at night, nocturnal paresthesia, so forth. So my thought process, he didn't like jump out at me that it was like a cervical issue. It was more like a median neuropathy at the wrist, but it was severe. So he's like I don't have carpal tunnel because like none of my testing that I did, he was a physician, he did Durkin's, he did Tinel's, he did Phelan's, like all of that was like negative. So one thing that we see is in these severe cases, like the nerve's so gone that none of that testing is positive anyway. So that was like kind of an aha moment for him. But, understanding that the patient has a superimposed, median neuropathy at risk is going to help tremendously with your outcome. So absolutely, it changes the way we treat patients.
Thank you. There is a question actually from Lucas.
How do you all handle therapists in the early stages of like implementing this as far as, and I think it's a good concern to have, but I always say it's a bell curve. Physical therapists are on one side, orthopedic doctors on the other side of the ordering diagnostic continuum and like overutilization of it versus underutilization. But really so like I feel like therapists more so, at least in our company, have a high concern of cost, which I think is a good thing, but they're so worried about the cost that they don't even bring it up because they don't want to increase the cost of care.
So I think it goes back to your culture, and it goes back to educating your therapist. So the first time that, that therapist comes to you and says, "Hey, I don't think this patient needs this," then we look at, all right, what was your outcome with that patient? How many times did you see that patient? Did you keep that patient in our clinic for 40 visits and then send them to a spine doctor to have surgery? Like, how is that managing the cost of that patient's care? We see that when we have an accurate diagnosis, the cost of care actually goes down because we don't keep those patients forever. We make good referrals out early when they don't get better. Let's use our cervical radiculopathy. You have a therapist that's treating that patient. If they're past 12 visits from me and that patient is not significantly better, they need looked at. They need another set of eyeballs. I'm not saying you have to discharge them, but make an appropriate referral. Get some additional studies done on that patient. So I think when we actually figure out that, man, we have the ability to accurately diagnose these patients, the cost of care actually goes down for that patient. And we have a culture where if you're seeing a patient for 40 visits and they have surgery after that, like that's an issue for me. That is not utilization of good care for that patient's money.
And I will add to that, one of the biggest mistakes we make in healthcare in general, not just physical therapy, is looking at various services in silo. You have the physical therapy silo, the surgical silo, the imaging silo, the primary care silo, looking at them separately. So look, if you can use this, which is the PT with diagnostics that provided you with a more accurate, more precise diagnosis, it provided you really the root of the patient's problem, okay? Not for all patients, but the specific subset of patients that was required. And it can help you to eliminate this, which is all the other stuff. I'll go for this. And of course, I'm not going to go for what also the other example that Dan gave, which is you get a patient, a whole bunch of physical therapy visits, for the physical therapy to fail because it was not appropriate for that patient, and then for the patient to get, after failed PT, the surgery or whatever, and for the patient, if they still have benefits afterwards, to get another so many sessions of physical therapy. That is a failed system. The appropriate system, the most economical system, is for that patient not even to go to a primary care initially. Why? Because the physical therapist is supposed to be the primary care specialist, the primary care provider for the neuromusculoskeletal problems. And the physical therapist then to identify which of these patients, besides their physical examination, require to do other appropriate studies, such as electrodiagnostic studies, get to the root of the problem, and get to treat the patient properly. I absolutely prefer to have a total of 12 PT visits and an EMG than to have 12 PT visits, then an MRI because PT failed, then the EMG, then the surgery, then whatever.
Just kind of tag on to what you said. We also don't want 12 visits, then an EMG, and 12 more visits. If we can do it in the beginning and have the best knowledge in going into our physical therapy visits, we're only getting so many visits approved with insurance. So we need to get patients better faster. So we need all the information we can at the beginning. And we did a survey at Court about the barriers of, what barriers they're having to refer to diagnostic testing. And a lot of the answers were, we don't think we need it, or we'll refer if we're not getting anywhere with treatment. If we've used up all these visits already and then refer out to get a better picture so we can, have more specific treatment sessions, we should have done that in the beginning. We could have saved a lot of those visits and getting that patient better faster.
And this is why we are using this tool, because this screening tool, the diagnostic testing screening tool, is your medical qualifier for diagnostic testing. All right. So when the patient has, radiating pain, radicular pain, numbness, tingling sensation, there is a reason for you to refer immediately to diagnostic testing, to an EMG. Because if you do not, then what happens is that if you don't identify the patient's true pathology and you wait until you have some profound weakness, then the patient's recovery is not going to be the same. It's a disservice to the patient and a disservice to the system, I might say.
Within the last 6 months, we go to a local orthopedic group and do EMGs for them. I had probably 3 patients come in, and essentially it was I did a carpal tunnel surgery on this patient, and they had no changes. Essentially, their condition is the same. So we did the EMG, and essentially it came up that the patient had polyneuropathy. So they released the median nerve right at the wrist, but the entire nerve was gone. So that's why it didn't help. Understanding that, yeah, like the patient came into the surgeon and said, yeah, I have numbness like in my hand. And he's like, do you have numbness in these 3 fingers? Yeah. Does it wake you up at night? Yeah. Does that make it tingle? Yeah, a little bit. So he does surgery, but essentially the entire length of the nerve was gone. So the release didn't work. So, when you talk about talking to your clinicians about that, like that's important to know. Like if you're going to make an appropriate referral, like, yeah, all right, refer that patient. They didn't get better, refer them out to a hand specialist. He does surgery. It doesn't go well, doesn't get better. Then they're like, hey, you made a terrible referral. Like this patient didn't have, carpal tunnel. So getting that information, like Amy was saying, like in the beginning, like it's huge as far as managing the cost of that patient and the outcomes.
Thank you. Any last comments from you?
Yeah, I just appreciate everything that like this whole group does for our profession. Like I'm very grateful to be a part of it and honored that you asked me to talk on this. So thank you.
Thank you for joining me in today's episode of Your Practice, Your Money, where clinical success meets financial freedom. If you found value in today's episode, please remember to subscribe here or on Apple Podcasts, on Spotify or YouTube. And please leave us a review and share about our podcast to your friends and colleagues, because this can help more practice owners add value to their practices and solve everyday problems. For more strategies, resources, and tools to help you grow both your clinical impact and your financial freedom, head over to www.yourpracticeyourmoney.com. Until next time, keep building the practice and the life you deserve. Take care.